Good evening, everyone. Welcome to our sixth and final session of Child Mental Health Community of Practice, Gender Diversity. We would like to start our session today by the acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon Wurrung people, and Wadwurrung people. We pay respects to elders past, present, and emerging, as well as pay respect to any Aboriginal and Torres Strait Islander people in the session with us today. Just some community of practice guidelines. We agree to stay on mute unless speaking, raise your hand to speak, keep conversations confidential, and if possible, please keep your camera on. Introduce yourself and your role when speaking, share ideas and promote everyone's participation. Acknowledge that we have varied learning needs and interests, and ask questions because no question is silly. During the education component, please ask questions via chat box. This session is being recorded. Please ensure you join the session using the name you registered with so that we can mark your attendance, and certificates and CPD will not be issued if we cannot confirm your attendance. I'm sure you all are quite familiar, but these are the ways how you can change your name. So if you are attending through an app, click on your name. If you are joining the session on desktop, click on your name and click the three dots. And from Mac, just hover over your name and click more, and then please rename. We have Dr. Prakash today with us. He's our main presenter psychiatrist. He's a senior consultant and child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. He has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. I'm Saha. I am a GP who has been working in Sunbury, and my area of interests are child and adolescent mental health and chronic disease management. And our guest speaker for tonight is Dr. Tram. She's a psychiatrist and mental health lead at RCH Gender Service. Tram has had a breadth of experience working with young people and their families. She's a strong advocate for those who are vulnerable and marginalized. She's excited and privileged by the opportunity to work with young gender diverse people and their families through their journey at the Gender Service. So I'm going to just hand it over to Dr. Tram now. Thank you. Thanks, Tram.
Thanks. I'm just going to share my screen. And I'd really like to thank everyone who's made it here today. We were just commenting that this is towards the end of the year, and lots of people have reached their CPD requirements. So my hat's off to you as we're heading close to Christmas for attending. And I also know that there will be people requesting the recordings as well. I know I have a bunch of recordings that I'll probably see if I can get to over the Christmas break. So I'm Dr. Tram Nguyen, I'm a psychiatrist, and my pronouns are she and her. And we said this wouldn't work, didn't we? Okay. We did have a try and it worked better when we had the try. I would also like to acknowledge country and the Wurundjeri people where the lands on which I work, rest, play, and acknowledge the resilience, strength and capacity of First Nations people, and pay my respects to the elders past, present, and those who are emerging. But I'd like to particularly acknowledge the impact of colonisation on Aboriginal and Torres Strait Islander people with regards to sister girls and brother boys who are gender diverse and have been so for tens of thousands of years throughout Australia. And it's through erasure and that we've actually not had that knowledge within our teachings. Another point of acknowledgement is that I'm a cisgendered woman, and so I try and take on what I hear from people who are in trans community, and so that their voices are heard, and it's not just my voice. So sometimes I will talk about what other people have said to me. And I'd also like everyone to think about taking a conscious effort. It does take a conscious effort to disrupt the habits of how we see things. and how we see things through our own assumptions. So probably one of the reasons why everyone's here today is that there has been an increased awareness around trans identities, and we see that throughout the media. And some of it's very good because it's visible for people to be able to reflect, to see themselves mirrored in public spaces, but it's also led to lots of negative press, lots of trans hate, which has been really damaging to trans community worldwide. So we've got Georgie Stone here and Elliot Page. And Georgie Stone was one of the young people who came in through our service as a young person. When we look at numbers, and another reason probably why you're all here is that if you're working with young people, you will see trans and gender diverse people within the group that you see. And when we look at so-called prevalence data, the La Trobe study of a couple of years ago of year 10 to 12 students, 2.3 reported being trans or gender diverse. Another study of over 20,000 online respondents from Mission Australia report 3.7 self-reported being gender diverse, and 1.3 stated that they preferred not to say their gender. And actually, I think the numbers are a lot higher than this because there's lots of people who haven't come to the language. And I also think this also misses a lot of culturally diverse communities. And we know that within cultures such as through parts of Asia and India, there's always been trans identities that people have had and have a place in culture, and the numbers are probably going to be higher. And also, I was speaking to a psychiatrist over in New Zealand, and they're doing a whole of life study of prevalence, and actually there's an increased number of people in their 50s and 60s now identifying as transgender. And growing up, they never had the words for it or never had that visibility, and now coming out as trans and affirming their gender in their middle age. So this is a map, and if you put this into your Google search engine or your preferred search engine, you'll find it as a World Gender Customs map, and it's an interactive map. And when you click on any of those blue pins, you'll get a history of trans and gender diverse identities and cultures across the world. And there have been gender diverse identities throughout all of the world through time in all continents other than Antarctica. And what you might notice if you can see it up close is there's no blue dot over the United Kingdom. And that's what we've inherited in terms of our colonisation. And that's why we haven't had trans visibility up until recently, where that has been the case through older cultures. So coming on to terminology, and this is important because it's easy to get confused. So back in the old days when I had children, and my eldest is nearly 18, the story was the midwife or obstetrician would hold up your baby and say, and you've got a whatever. And that was how sex was defined. But we actually know that sex, and to some degree gender, we also know that sex is more complex than that. Those of you who are medical know that sometimes chromosomes do not reflect genitals, and there are people who are considered intersex. So it is not a binary construct, as some people would say that you might hear in the media. And then the concepts of sexuality and gender. So sexuality is regarding attractions that you might feel physical, sexual, emotional towards another. And it's mostly interpersonal. And I say that because sometimes people might be in a committed relationship that's heterosexual, but in their minds, there might be attractions towards another. So it could be, it's how your personal attractions. Gender is one's concept of oneself, internally felt. It's a deep feeling as being male or female, non-binary, beyond the binary, and it's mostly personal. So And that's sexuality and gender are two different things. So people get mixed up. So sometimes parents or older people, when a young person says I'm trans, they might say, the reaction might be, are you sure you're not gay? And actually they're very different things. And I say gender identity is mostly personal, but we're also social creatures. So we learn about our identities through others. So that, for instance, the construct of non-binary, there was no word for it. So people didn't have that language previously. And really it's difficult to be what you cannot see. Also, how we understand ourselves. So I feel most female when I'm in a room with males because I notice that difference. And young people will say that, I was put in a group of girls and I realized now that I wasn't a girl because I wasn't like them. The difference in language is difficult because we have the same terms for sex and gender, and that's a real problem with our language. And so sometimes there's confusion and conflation of the two. Some other terms, assumed or assigned male at birth or female at birth. And quite often we use this, particularly when I'm using this in terms of people who are non-binary. So actually when we think about what kind of organs or anatomy people might have, and therefore what kind of hormones they might want. Cisgender is someone like myself, where my gender identity aligns with my sex assigned at birth. And someone who's trans or transgender, quite often we use trans for short, is where someone's gender identity is not aligned or not congruent with their sex assigned at birth. And non-binary is part of trans. Some people will say in brackets trans, in brackets binary and non-binary, who may not identify as male or female in that binary way. And someone who's gender fluid has a gender identity that varies over time. Though I would say most of us have some variation in our identities over time. But what is most important, and one of the themes that is around, I think, just asking. So some people might say that, I have this is my name, but I prefer not to use pronouns because I don't identify as any of those pronouns, for example. And so we always check in, and there's always new language. And as people with old brains, we just have to be a bit flexible in our cognitive capacities to do that. The terms gender non-conforming and gender expansive really just refers to people who don't conform to cultural expectations. So it doesn't necessarily mean that someone's trans, and I'll talk a bit more about that. I've mentioned gender identity. Gender expression is how one might present one gender's outside. So it's through, these days, it might be through our name, our clothing, our behaviour, mannerisms, hairstyle, voice, and things that are socially defined as gender in terms of masculine and feminine. And some people say, I don't want people to actually assume I'm a particular gender. So I actually want to present something that's a bit more challenging or confusing to people. This is one of the tools that we might speak with young people about. And actually, I find it really useful to speak with parents about, because parents quite often see expression and identity as similar. And so it's if we have a young person who doesn't quite exactly conform to a gender stereotype, parents might get confused. And then I might get parents and young people to draw themselves along the various charts. And then it gets parents to think about their gender as well. As I mentioned, people can be gender expansive or gender non-conforming or gender variant, as some of the older language, and not actually be transgender. And I bring this up because a lot of the old studies that say that children grow out of it or change their mind, a lot of those children were not transgender. They were gender expansive. It was back in the 80s, and parents got stressed that little Johnny preferred to play with Barbie dolls and then took them to a gender clinic. Where, there was one in Canada that told the parents, take all the Barbie dolls away, and then they'll continue to identify as male. But really, most of them might have identified as male all along. And this is an example how we're still seeing that someone who's male identified who wears a bit of makeup and a dress is seen to be gender non-conforming and challenging gender norms. Whereas things are different for people who are assigned female at birth who can wear pants with no issue. And back in the 1900s, it was an issue. It was illegal for women to wear pants in public, and people would be imprisoned for it. And there's a history of people who were probably gender diverse back in those times and would repeatedly be imprisoned for wearing pants as female assigned at birth. So I put this slide in to give you the definition, the DSM-5 criteria, but on the proviso that it's actually really not helpful. So if you read down the criteria, the main one is around identity, but the rest is just around preferences, likes, interests, which are all stereotyped. And if we have then what it does is just emphasizes stereotyped gendered behavior. And it says things like the other gender, which doesn't include a non-binary concept into it. And it assumes that there's only one way to be gender diverse and only one way to be trans. So lots of trans community will take offence to this, and hoping there is work towards getting gender dysphoria actually removed from DSM. It's a little bit tricky because DSM comes out of America, and one often needs a diagnosis to access medical care through insurance companies. So we will see how that evolves. Whereas the ICD-11 from the World Health Organization doesn't have a category for gender dysphoria under mental health conditions. It has gender incongruence, and the features are very similar in childhood and in adults. And it's actually under the chapter of conditions of I think it's sexual disorders or sexual conditions rather than under mental health. And it talks about the incongruence of an experience or an expressed gender that is different to that assigned at birth. And it does talk about desires and dislikes or likes and preferences, but it says that the variant behaviour and preferences alone are not the basis for assigning the diagnosis. And that really, it's when a child says, I am a girl, or I want to be a girl, or when I grow up, I want to be a woman, that is what we take into account, rather than, you know, I like to play with this, or this is what I like to wear, which is gender expression and preference. And where that is sometimes confusing for parents is if you have a young person who's neurodivergent, so someone with autism, they may not read those gendered social cues. So for them, the criteria around other gendered preferences doesn't work because they have non-gendered preferences anyway. They don't read the gender social cues. So a reflection. So when were you first aware of your gender identity? And most people would say, I've always known it. I can't remember not knowing. Or people might say, you know, sometime at school, very early on. And how do you currently embody and express your gender? And we all do this. You know, I do this very much more consciously because I work in gender, but, you know, you will only ever see me in a dress at work and makeup. And that's how I like to express my gender. But people can express their gender in different ways. And it doesn't necessarily have to be aligned to a gender identity. So someone who's assigned female at birth, and I'm using this term in a very respectful way that community likes to use, can be a butch lesbian and have short hair and sort of have a masculine type of expression. Or you can have an androgynous expression, but we all, you know, express our gender in a particular way. So what would it be like if people do not perceive your gender identity as you experience it? And I've been misgendered. I've been misgendered twice, and I remember both times because it's just so distinctive to me. It was online, on email, both times by women because of my name, and I have doctor in front of me. They both assumed that I was male, and I was like very offended. So, you know, just think about how that would be if you're misgendered. So I've got a couple of slides on gender development. So thinking about when you might have first experienced your gender, and actually infants can pick gender in studies that look at voice, so they can pick feminine range of voice versus masculine range of voice. We know lots of studies in utero that infants begin to hear in utero, babies. And children from the age of 2 are aware of physical features, so some of it's around facial features. By the time they're 3, most kids can say that I'm a boy and that person's also a boy. And by about 4, they have a reasonably stable sense of gender identity for the most part. And then as they go into the ages of 5 and 6, they realise that people have a consistent gender identity through time. So someone who is a boy will grow up to be a man, and that they also begin to realise that your gender identity doesn't change if you get dressed up. So if you go into childcare and kinder and you get dressed up, you can be a boy and dressed up as Elsa, but you're still a boy, for instance. So they still can understand that concept of consistency and stability. And that across these ages, it's actually really lovely. When you go into childcare and kinder, you see kids, you see boys come home with nail polish, and the kids are much more freer to dress up and play. And it's actually when they reach school that there's a lot more gendered segregation. So, you know, boys over there, girls over here, boys' uniform, girls' uniform. And that's where we quite often begin to see kids becoming distressed and parents seeking help around how do I support my young person, because this is one of the reasons why school is uncomfortable for them. And the studies show that children who are gender diverse and are trans have the same gender identity development through time as cisgendered children. And gender norms are continuously reinforced. Like, I hear it surprisingly from my niece, who was 3, who said that her grandfather couldn't wear a necklace because necklaces are for girls. And it's like, you're 3 and you haven't been brought up with, gendered parents, and yet this is the case. And certainly when I was growing up, there wasn't boys and girls sections of clothing in Kmart and Target, and that's a relatively new phenomenon because capitalism realised that you could sell twice the number of garments and what have you if the children didn't hand down things that were, in yellow and green and purple and gender neutral colours. So we are continuously having it reinforced, and language such as, don't run like a girl, be a man, don't cry, only girls cry. So all these kinds of phrases and language, and that actually, in reality, those who are assigned male at birth are policed a lot more around gender than actually those who are assigned female. And that's why early on we get the referrals we have many more of trans girls assigned male at birth referred earlier, because that's what parents pick up. And then the assigned females get referred a bit later because you can get away with being a tomboy and wearing shorts. And it's actually when you actually express it to your parents that you get a referral to come and see us. But earlier on, we see a lot more assigned males. And this is just to show that quite often sexual development starts later, sexual orientation around puberty. This is just a generalisation. I know that there are some young people who say they've always known that they were straight, always known that they were gay from, grade 1. But overall, the sexual orientation development develops later. Where it can sometimes get a bit confusing is around sexuality and gender for parents. I've heard some young people say, oh, I said that I was gay, So I could test my parents to see whether they were okay with it. And if they were okay with it, then I told them I was trans, but I just wanted to test the water first. Or for some people where they haven't come across the concept of gender diversity, they might say, oh, I thought I was gay because I like boys, but then I realized actually I wanted to be a girl with a boy. I didn't want to be a boy with a boy. So I wasn't really gay, and that's how they came to understand gender diversity. So they might have spoken about being gay first because that's how they came to understand it for themselves. So in recapping, gender diversity is not a mental health condition, and it's been a part of human existence for a very long time, and that there is no treatment that is necessary or warranted for people with trans identities, and across the world quite often there hasn't been treatment because there's been acceptance within community. And when you hear about the high mental health rates for trans and gender diverse people, it's actually due to the social response that they've received, which is rejection, misunderstanding, social exclusion, bullying, marginalisation, institutional barriers, including schools, and negative attitudes. Gender dysphoria, and there are two parts of gender dysphoria, may benefit from support and intervention. So the two parts of it are, so some people feel a dysphoria within their bodies, a discomfort within that, but not everyone feels that. And some people say they only have social dysphoria. So when they interact with the outside world, I have a trans boy who at 14, he sort of said, oh, I'm not sure about testosterone, because mostly when I'm sitting in my room, I'm actually okay with myself. I just see myself as a boy and I play my games, and online when I'm a boy. But it's actually when I walk out and everyone, says that I'm a girl, my voice is too high. That's when I feel the dysphoria rather than in myself. And, I've had people say, I wish people would just be able to see me without me having to change. This is the Trans Pathway study from WA, but a collection, it surveys nationwide young people's experiences. And the sobering numbers are that these people, young people, have self-reported whether or not they've been given the diagnosis, and that over 70% have been diagnosed with depression, anxiety. 22% have been diagnosed with an eating disorder, and sometimes that's to do things like suppressed menses or discomfort with body changes. And 80% have self-harmed, and 48% have attempted suicide. So these are much higher rates than in the general population. This is a newer study from a couple of years ago, writing themselves in 4, and there's still some analysis from the data. So more papers have been written from this study of 6,500 young people, and similarly high rates of psychological distress, suicide ideation, self-harm. And when they got asked about what are the contributors to this, actually what was found was that it was due to high rates of verbal harassment. I've heard lots of bullying, name calling that I can't even fathom, physical harassment, being pushed about, having books or things thrown at them, sexual harassment, and that's the highest in trans women or trans girls. So trans women overall have experienced sexual assault at much higher rates than even cis women. And then feeling uncomfortable and unsafe in educational settings. And in addition, about half experienced misgendering and another half have been outed, which means like they don't want other people from the school to know about their trans identity because it's not safe sometimes, but being outed, and that can be quite distressing for young people. And it's one of the reasons why there's lots of school avoidance in the population of young people that we see. So what do we provide at the Gender Service? We do a lot of listening. And actually you will see a mental health clinician several times before you see a medical person. We empathise. We're self-aware, particularly those of us who are cisgendered. we take a non-judgmental approach, and young people are more likely to speak and be honest when they know it's a safe space. And we put the young person at the centre of the decision-making. So we take a very person-centred approach while we do have a family focus. We respect people's pronouns and names. We assist with social affirmation and identity documents if needed. And then the medical component may or may not happen. So this is something that can be done anywhere. It doesn't need to be done at the gender service at the Children's Hospital, and that's social affirmation. And just a note on language, some people in trans community will still use transition, and some you might come across it as transition, and we don't use it because it assumes that someone, say, is born male and is changing to female, whereas people will say, I've always been female, I'm just affirming my gender, so I'm not transitioning, this is how I've always felt. And so that's a language we use as preferred by community. And as I mentioned, this is where parents will say there's a real difference when I let the young person cut their hair. They were euphoric and so happy, or that when I bought them these dolls, that's what they really loved. So those little things that seem little are actually really big things for young people. Legal name changes and gender markers, this is a big thing, and it's a bit complicated depending on what kind of documents, because there's Medicare, there's passports, there's birth, deaths and marriages that goes into enrolments. So there's a lot of administrative work that parents have to do for this. And then other things in terms of body wear, binders, tuckers, padded bras, padded underwear. And then a choice around how one interacts with gendered spaces, such as toilets, change rooms and camp. And these are really important because we have some young people who don't drink throughout the day because they don't want to go to the toilet while at school because none of it is comfortable for them. And a disabled toilet is not sufficient because they will say, I'm not disabled. So this is something that we advocate for. There are guidelines on the Victorian Department of Education website regarding this, and there are similar guidelines in the Catholic Education Department as well. And Safe Schools are a really good resource to ring, and they can assist with those guidelines if you're uncertain. Just a comment on the disabled bathrooms. And really what's important. Now, I'm just making a little note on puberty suppression because it gets talked about a lot, and they're medicines which they work in the brain and stop puberty at the point that people are at. And there is no medication indicated for someone who's a child and pre-pubertal. And there's generally a preferred time when puberty suppression is given, and that it's reversible, whereas puberty is not. Once you go through puberty, you can't turn back and reverse time. But what it means is it allows for decreased distress, it allows time for young people to just sort of think, oh, the changes are coming, the change is coming. Once we see that settle, people can then think more about their gender. They can interact with their peers and understand how gender and puberty might develop. And we've actually seen now young people, I've had a young person go on blockers, come off blockers, felt distress again, go back on blockers. And so it is, we use it in a different way rather than necessarily always towards a pathway of medical affirmation to testosterone or estrogen. We actually use it now for exploration. It's one of the things that we tend to have to keep at the Children's Hospital because it's really expensive. It's about $4,000, $4,000 to $5,000 a year, and we subsidise it. And in the private sector, it's really hard for parents to afford that. And we use the same medicines that are used in precocious puberty. So we think about medical affirmation. I've mentioned the blockers. For people who are post-pubertal, there are androgen blockers, and they include cyproterone and spironolactone. And for menstrual suppression, we generally use Primalute, but people use other things such as the combined oral contraceptive pill or for some older adolescents, the Mirena or Implanon is no Depo-Provera, but there are mood issues with that. And then there's estrogen and testosterone. I know this is a mixed audience tonight, so I haven't gone into all the medical components, but there are easy access resources around prescribing, and it's actually not that hard. If you've done, prescribing for the oral contraceptive pill or HRT for menopause, the prescribing is similar, and thinking about the risks are similar in terms of, say, smoking and blood clotting, and what you might measure there and monitor in terms of bloods. Surgical affirmation I've only put here for completeness, and despite what you hear, it's actually in adults. And there are a couple of surgeons who might do chest surgery for under 18s interstate, but not in Victoria. And so this is, when you hear about it in the media, it's untrue around surgery for young people. So this is quickly to go through the model of care that we have. So we actually, if you're referring into us, we do have a triage assessment session. It's a one-off session that looks at young people's pubertal status, so that we actually fast track those who are peripubertal, whereas those who are post-pubertal sit on our general wait list, which is a lot longer. That's because we know that there's only a limited window where we can actually prescribe puberty blockers. And after that point, we actually find that a quarter of young people actually don't continue with the service. They have all the information that they have. They might explore gender in different ways and take a non-medical pathway. So 3/4 would then progress to our multidisciplinary clinic. And then the options for treatment do involve things such as puberty suppression, hormones, and surgery. I've just put there for completeness. It's in red because we don't provide it. And the stages I've put there because that's the legal stages within what the family court uses. But as I'll go on to show, there's not a linear pattern. People don't have to go through any particular way that they choose to do things. So as I mentioned, people can choose social affirmation, and we see that particularly in non-binary young people, and that is sufficient. People might come to us and have puberty suppression and then decide, for instance, they will continue on their endogenous puberty. And you can't go on you can't stay on blockers forever, because you need sex hormones, estrogen or testosterone, for bone mineral density. So at some stage, people have to choose which puberty is their preferred. Probably a lot of our young people might come in too late for blockers. They might choose to have estrogen or testosterone plus or minus surgery when they are adults. And we have some young people who come in and say, I just want the top surgery. I actually don't want hormones. And they will then come in, see us, and have some education, and then go to and wait until they're adults to access surgery. And this is a slide on the persistence of trans identity. So these are young people who are socially transitioned or affirmed, and none of them had any medical treatment. And this longitudinal study showed that of those who came in through this service, 2.5% continued living as cisgender, but the vast majority continued as being transgender. And what we've found now through our practice in recent years, that some people come in and they identify as a trans male, and then they might end up identifying as non-binary. Or I've had others who've identified as non-binary and then moved towards being transmasculine. So that's what we see more commonly, people moving within that trans identity rather than moving to a cis-gendered identity. And just a comment on, again, if you're reading the literature, there's talk about regret, retransition, And it's much more nuanced than that. So some people, we say retransition or reaffirm because they might reaffirm to another trans identity, and that people might change their mind about treatment or stop treatment without actually returning to their cisgendered identity. So I have some young people who are post-pubertal, they start on testosterone, they want some of the early changes, voice deepening, and some redistribution of body fat perhaps, but it's mainly the voice. But they don't want to be what they call hypermass. They don't want a full beard, so they stop it after a year, and then they continue and they say, well, I might have top surgery later on, but I don't really need to continue the testosterone. And when we actually look at regret rates, and this is a large cohort study in the Netherlands that showed that actually the rates of regret of having surgery and medical affirmation is actually really, really low. And trans affirming surgery, regret rate of 1% is actually the lowest regret rate of any type of surgery that people have in Australia. And the regret is quite often due to things like social rejection, people losing partners, or family rejection, sometimes is loss of employment. So this is a lot of the 10 things that young people want their doctors to know, but any health professional to know, that gender and sexuality are different things. Talking to strangers about this is really uncomfortable, that non-binary people exist, that names and pronouns and gender markers are important. Don't ask me about my genitals unless it's medically necessary. Physical examinations are uncomfortable for everyone, but especially for me. Gender-affirming hormonal interventions can save my life. Please train your staff. Many of us have had visits starting with the wrong tone, starting with check-in, so front of house. This can make me shut down. If I'm depressed or anxious, it's not because I have issues with my gender, but because everyone else does. And let me know that you're on my team. And so I will probably finish with this. I've had some more slides, but I'll finish with this, thinking about what cultural safety looks like. And I'm finishing with this because I spent last week at the coroner's court, and what was heard around the suicide deaths of 5 trans young people is that they were really hesitant to seek mental health support and inpatient admissions because they didn't feel that there was cultural safety there. And so the little things, the flags, the rainbow flags, or the posters, the pronoun badges, all those things make a real difference to people, to signpost that this might be safe for people to enter spaces, that names and pronouns are respected, that data systems allow for diversity. So I know some medical software is not particularly friendly around that, and how you can work around that for front of house staff, and not taking a normative approach to seeing people. So that cisgendered is not the only normative option. I will stop sharing there and then open up for questions. I do have a lot more slides, but in the interest of time, I won't go through them.
Thanks, Tran. That was amazing and very insightful. Stephen had a question regarding, is it possible to have organ transplant? I have heard they are transplanting uterus.
That is a really good question. So there has been one uterus transplant completed in Australia. I think from memory, it was for reasons not to do with gender. It has to do, I think it was someone with cancer, but that is potentially a possibility in the future. It will require obviously a lot of hormonal and, anti-rejection medicines, but who knows? Yeah.
Thanks, Tran. So we'll move forward to our next section, and then we'll come back to the questions when we discuss the case studies, if that's okay. So just going to some discussion regarding the health pathways. So with the health pathways, they are written by GP clinical editors with support from local GPs, hospital-based specialists, and other subject matter specialists. And this is how they look like. If any one of you hasn't really had a look, particularly GPs or anybody who works in the community setting, have a look at it. You can register, and here, and in terms of child health, mental health community of practice over our last 6 sessions, this slide would be sent over to you. It has really great resources when it comes to all those topics that we have discussed, particularly when it comes to gender diversity. There were some slides that I was having a look at. I'm just going to try and find them because they were really, really good in a GP sort of a setting, where pointing out to all the resources that you can potentially, look into when it comes to referrals and support services. So just in here, I just typed transgender or gender diversity, both of them, and it came up with all these services. I know we're talking about children and adolescents here, but it has links to services when it comes to supporting our adult population of patients as well. And also, there were some really great resources when it comes to, links to support groups, services. Just going to find.
Can I add? Well, I'm actually within a group where we're just about to update the health pathways for the PHNs in the northwest region. So hopefully you'll see an updated version of that next year.
That's great. And that brings me to another thing. Whenever there is a feedback, they are very responsive to feedback. And even if you are having a look at a tram and you want to add something, I once sent a feedback and they were so quick to respond to it. So that was amazing. That means that, they're constantly trying to update as well. Thank you so much for adding